presentation 1. This patient has a right congruous homonymous hemianopia. This suggests a lesion behind the optic chiasm, but more specifically behind lateral geniculate ganglion, affecting the left optic radiation. The differential diagnosis includes cerebrovascular occident, infarct or hemorrhage, intracranial tumor, trauma. Clinical notes. A homonymous hemianopia indicates a lesion behind the optic chiasm. However, lesions of the optic tract produce incongruous defects, as fibers serving identical points in the homonymous fields from both eyes do not fully commingle in the anterior optic tract. Lesions behind the lateral geniculate ganglion, affecting the optic radiation, produce congruous visual field defects. Thus, a right incongruous homonymous hemianopia would indicate a lesion of the left optic tract or lateral geniculate ganglion, whereas a right congruous homonymous hemianopia indicates a lesion in the posterior optic pathways behind the lateral geniculate body, affecting the left optic radiation. Having made the diagnosis of a right congruous homonymous hemianopia, look for the following: left craniotomy scars, previous trauma or surgery, right hemiparesis, dysphagia, left dominant hemisphere involvement. Case presentation 2. This patient has a bitemporal hemianopia. This suggests a lesion at the optic chiasm. The differential diagnosis includes pituitary tumor, craniopharyngioma, suprasellar meningioma, glioma, granuloma, metastasis. Clinical notes. Bitemporal hemianopia is relatively straightforward to deduce from visual field testing. It is important to remember that pituitary tumors compress the optic chiasm from below, whilst craniopharyngiomas compress the optic chiasm from above. Chiasmal compression from below affects the lower nasal, upper temporal field fibers first, then the upper nasal fibers. Chiasmal compression from above affects the upper nasal, lower temporal field fibers first, then the lower nasal fibers. Thus, pituitary tumors result in temporal hemianopia that progresses from upper to lower fields, and craniopharyngiomas result in temporal hemianopia that progresses from lower to upper fields. Having made the diagnosis of a bitemporal hemianopia, look for features of pituitary tumor, acromegaly, Cushing's disease, hypopituitarism and gynecomastia, granulomatous disease, sarcoidosis, tuberculosis, metastasis, evidence of primary malignancy. Case presentation 3. This patient has a right homonymous upper quadrant anopia. This suggests a lesion in the left temporal cortex. The differential diagnosis includes cerebrovascular accident, infarct or hemorrhage, intracranial tumor, trauma, surgery. Clinical notes. Fibers from the upper quadrants leave the optic tracts to become the optic radiation that pass anteriorly to form Meyer's loops in the temporal lobe. These fibers loop back posteriorly to join the lower quadrant fibers in the parietal lobe. Temporal lobe lesions, therefore, result in a homonymous upper quadrant anopia. Having made the diagnosis of a right homonymous quadrant anopia, look for the following: left craniotomy scars, previous trauma or surgery, right hemiparesis, dysphagia, left dominant hemisphere involvement. Case presentation 4. This patient has a right homonymous lower quadrant anopia. This suggests a lesion in the left, anterior, parietal cortex. The differential diagnosis includes cerebrovascular accident, infarct or hemorrhage, intracranial tumor, trauma. Clinical notes: the anterior parietal part of the optic radiation carries fibers from the lower quadrant. Thus, lesions affecting the anterior parietal lobe result in a homonymous lower quadrant anopia. These fibers are quickly joined by upper fibers, sweeping up from the temporal lobe. Thus, parietal lobe lesions often produce a complete homonymous hemianopia. Having made the diagnosis of a right homonymous lower quadrant anopia, look for the following: left craniotomy scars, previous trauma or surgery, right hemiparesis. Case presentation 5. This patient has a right nasal visual field defect. The differential diagnosis includes chronic, open-angle, glaucoma, retinal disease, lateral chiasma compression. Clinical notes: demonstrating an isolated nasal visual field defect, nasal hemianopia can often baffle candidates, but it can occur, and it is important to be aware of the principal causes. Having demonstrated such a defect, it is important to perform a fundoscopic examination with an ophthalmoscope. This will identify glaucoma or retinal disease. Cupping of the optic disc. A hollowed-out appearance of the optic disc is an important feature of chronic glaucoma. Generally, a cup-disc ratio 0.5 is a useful threshold for suspicion of glaucoma. As the disc cups posteriorly, the margins of the disc are steep and overhang the cup portion of the disc. The retinal vessel suggests the appearance of vessels being broken off at the disc margin. A nasal field defect can reflect disease in the temporal retina, and it is important to look for an area of chorioretinitis, branch retinal artery occlusion, or branch retinal vein occlusion. Lateral chiasmal compression is rare, but can occur due to dilatation of the intravenous part of an atherosclerotic carotid artery, and occurs in elderly female patients. This impinges on the lateral aspect of the chiasm. This unilateral defect, that become bilateral, if the chiasm is pushed against the carotid artery on the opposite side.